Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Hello and welcome back. This is Dr. Adam Stryker, editor and host of Central Line. Today, I have a special treat for everyone. To wrap up the year, we're going to revisit some of the excellent programming from Anesthesiology 2025 and listen in on some of the interviews between TopMedTalk's host and our specialties leaders. We're going to start with our incoming and outgoing presidents and hear what they had to say. Dr. Don Arnold, ASA's outgoing president, spoke to his proudest achievements.
One of the things that I'm really proud of is how we have, as a leadership group, identified 4 core strategic priorities that we think are essential to evolving the arc of the profession in a positive way over the next 3 to 5 years. ASA is just brimming with talent and the capacity for innovation. But I think what we have done this past year is provide a structure that prioritizes areas that are critically important. And then we channel that work in advancing anesthesiology care with an emphasis on quality safety, on outcomes, patient and provider interactions and efficiency. That's one of our priorities. Second priority is increasing visibility and voice of the profession, which is critically important for the advocacy we need at this point in time. Third is advancing the understanding and adoption of new technologies. And finally, work that is really foundational to ensure the economic integrity of this specialty. So these are the 4 areas that we've prioritized and tried to express work. And I think how we've executed on that in a really dynamic time is probably what I'm most proud of.
He zoomed in on one specific priority, the Center for Perioperative Medicine.
The Center for Perioperative Medicine, frankly, is the first initiative under our first core strategic priority, which is advancing anesthesiology care. ASA is serving as a foundation for organizations to improve understanding, awareness, and the ability to implement perioperative medicine principles. A year ago, we met just as anesthesiology societies, both within the United States and internationally. This year, we had a summit on Friday, and we were really pleased with the number of surgical societies that are now participating as well. We believe that there's a lot of momentum in this space. We think fundamentally there's the potential to reshape care delivery in the United States, improving outcomes and improving efficiency of care.
Dr. Patrick Giam, ASA's incoming president, discussed how this effort might be expanded.
One of the big roles and the opportunities for big societies like ours to bring together other stakeholders, other organizations on a common theme and common issues. In this case, it's perioperative medicine, which is certainly critically important, but we can also bring them together on other economic issues or advocacy issues, and the ability to bring in these wide, disparate groups that work focused on things which help our patients.
Dr. Giam also shared his thoughts on initiatives he'll prioritize in the coming year.
Well, we're going to stay the course on a lot of the strong strategic agendas, much of which Don laid out. One other thing that I want to focus on is we do a lot of things as anesthesiologists and in the American Society of Anesthesiologists, but I wonder if all of our members are aware of the multitude of things that we're doing. So I'd like to help them understand what we're doing, how we're addressing it, how they can be involved, part of the member value equation. So one of the things I'll be focusing on in the coming years is making our communication style match our effectiveness out in the real world, but so that members can see it. So we'll be trying different communications means and different communication styles to help reach members in a way they want to hear and in methods they can hear it. So what might that be? We're going to have more frequent communication from the society, but shorter, more bullet point, highlighted documents that hopefully they can get through, even if they're busy in between operations or driving home. So we're going to have more of an emphasis on video and social media. And we've seen the power that social media can have back even when we were having the discussion with Anthem on limiting anesthesia payment for time-based reasons, which we thought was, of course, unreasonable. We found that the social media aspect really helped become a tipping point and a strong advocacy lever for us to help the public understand that the issues that we face as anesthesiologists and physicians are not just unique to us, but also affect them directly. And so we'll be looking to those methods for communication.
They both touched on their hopes for the future of our specialty, touting people and technology.
Begins with people. Just the unbridled potential of the American Society of Anesthesiologists is expressed through our engaged members who are on a day in, day out basis at the bedside, at the bench, in education, in leadership roles, really having dramatic impact in their facilities, their health systems, and the communities where they're providing care. So I think the people. I think the second item is somewhat related, and that's the explosion of interest in our specialty. Much greater interest and a very high fill rate in anesthesiology residency positions, but at the same time, an expansion in the number of nurse anesthetists and certified anesthesiologist assistants coming into the field.
Yeah.
Maybe the AI helps bring in the massive data streams, which we're responsible for and need to analyze on a second-by-second basis, and helps us bring that into a readable form where we can create knowledge and information to help drive our real-time decisions. So I think that can help clinicians supplement their understanding of what's going on, and even take these information granules from one patient, add it to thousands of patients, and create understanding of what might happen in populations. So that we take a patient with having this operation with these comorbidities in this center, and what kinds of things can we do to personalize care to make their journey a little bit easier and safer. So I think these are opportunities that we could see right off the bat for augmented intelligence, and I think the future is very high for that.
Both ASA leaders discussed the value of mentorship.
A key part of professionalism as a physician is looking at the profession as a whole.
Yep.
And what can you do to create an environment of practice, to create a healthcare system that will continue to improve? And a lot of that is supporting the next generation.
If you set up a process where you identify people who have talents and particularly who have interests in doing things outside of the operating room, then you find that cadre of folks who would be interested in doing organized medicine or contributing in another way. And that's what we seek to do. We seek to identify people and also let them know the opportunities of what's available outside the operating room, because a lot of times they're just not aware of what can happen outside.
ASA has done some work to develop mentoring programs. We have a program that identifies those individuals interested in serving as a mentor and those individual ASA members who are seeking a mentor, and putting them together in a way that supports individuals who want to give or contribute in those kind of ways. We think that's important, and ASA has leadership resources that we make available not only on the national level, but expressed through the components, because the component societies are really where the development of the next group of leaders nationally are coming from.
Dr. Giam plans to focus on growing ASA's commitment to mentorship in the coming year.
So I'm very excited about the incredible quality of the folks who are going into the anesthesiology field. You get these folks who have this high capacity, this high energy, and then you give them the opportunity. You show them how leadership, how creating alliances with other organizations can help further anesthesiology as a specialty and also help our patients as a population. So we're going to try to be with them along their journey, to support them, to show them things which will make their career more enriching and more valuable, not only to their patients, but to them also. And as a society, we want to be there with them for their entire career and help them through that journey. One of the things we like to do is to talk with resident groups about the importance of leadership, but not only the importance of it, but maybe highlight some of the elements that traditional medical education does not educate you enough to be a physician leader, that you need to understand what it takes to go from being a physician to becoming a physician leader, and how can we help you along that journey.
Workforce was also on tap for a discussion with Dr. Dale Peterson, former ASA president, along with Tom Miller, ASA's Director of Analytics and Research Services, and the Director for Anesthesia Workforce Studies. Dr. Peterson shared some good news.
Whenever we talk about workforce, it really is that balance of supply and demand, right? So really on the supply side, as best we can tell, amazingly, we've had a 40% increase in the last 10 years in the number of residents we have. It's really enough for the current job postings on gas work. So, about 2,300 or somewhere around there. And then if we look at the other professionals we work with, whether it's CAAs or nurse anesthetists, they are increasing their training as well. So the pipelines are, I would say, robust. And we're getting fabulous people.
Dr. Peterson also flags some trends that drive demand and feed our workforce worries.
Let's talk about the demand piece, because I think that is really the major factor that we're experiencing. And that really is this explosion in other procedural care. We call it the Nora care, whether it's your GI suite or it's the cath lab, or, we've moved a lot of procedures to less invasive procedures, and they're going all the way over your hospital system into, I call it the Timbuktu area. It creates a lot of demand and at the same time inefficiencies.
Yeah.
How do we manage through that? And when we look at the number of surgeons that are out there, we're creating more anesthesiologists than surgeons. Okay, than all the
Oh,
surgeons.
yeah.
But we're not keeping up if you add in all the proceduralists.
Yes.
So the cardiologist, the interventional radiologist, the whatever. I think even though you can do endoscopy, screening, colonoscopies, the old-fashioned way, I've had it done that way. They've all learned and know the studies that if you have anesthesiologists, anesthesia care team involved, they can get throughput, they can be more efficient.
Efficiency.
And, you're adding a level of safety there as well. That's a more of a demand that we didn't have before.
Mr. Miller also discussed the moving goalposts of the workforce challenge.
On the demand side, what we don't know is, are these just people that want doctors because they want to increase their market share, they want to grow, or is it really what's needed for the population?
No, that's true.
We do know that markets and even labor markets hate being in disequilibrium. So they're constantly in flux and constantly making changes. For despite the fact that anesthesiologists has outpaced in terms of numbers all other clinicians except interventional radiology, it still sometimes doesn't seem like enough. And so a particular market, a particular practice, a particular doctor may feel these strains of like, oh, it's going crazy, there's a huge shortage. What's really hard is we don't have a generally acceptable definition of what a shortage is.
Mr. Miller noted the role of retirement in shaping workforce supply.
Retirement is one of the toughest things to get a handle on, but there are two organizations that do a lot of projections, AAMC and then the Health Resources Services Administration. And both of those, if you look at their models, if they just change the assumption on how many people retire, that has the biggest impact on sort of supply and also shortage versus surplus. So
Yeah.
retirement's extremely important to get a handle on.
Yeah.
And so with compensation increasing, with people changing and getting worried about the financial future, some people are hanging on.
Dr. Peterson talked about the solutions that have worked in her organization.
Yeah, I'm in a part of South Texas where I had chronic shortages forever. What are ways that our department can extend ourselves, still oversee the quality of care,
Quality and
the
safety. Yeah.
protocols, the safety, which we're required to do by the CMS? How do we do that? Well, in our case, and I'm not the only one, we hired full-time, sort of retired or burned out or whatever you want to call them, pediatric intensivists who are very adept at drips and airways and all of that. I figured there were about 1,000 cases a year that could be pulled off of our pediatric anesthesiologist schedule that they could do. A big piece of that in pediatrics is MRI, and it's all about how you triage and how you set up your sedation program. Before a child is scheduled for an MRI, we have screening questions and things that we use, age, what health issues they may have, what kind of MRI, how long it's going to take. And so group one needs nothing. VR, watch a movie, they're going to be good to go, right? Group two, they're healthy kids for the most part. It's going to be less than an hour's study. We believe that our full-time other physician who specializes in just pediatric sedation can do that. And then we have group 3 that's going to require a pediatric anesthesiologist. And so we have a full day scheduled for the sedationist. And some of those kids may not even need sedation. If so, that's fine too. It'll just be monitored care, right? And so you can pull a lot off of your schedule. Even those hard LPs or things that were scheduled in your procedure room, your bare exams in kids that can be lengthy. All of those things could be pulled off your schedule. Pediatrics has done this. I haven't seen as
Yeah.
much of that in the adult world. It requires a team. So I had to hire sedation nurses. I had to hire physicians that specialize in this. We had to make sure we had the protocols in place.
Yeah.
We had to make sure that we're working with the other service lines so that we take over scheduling. No, you can't schedule a case before we have done the triage process. So we work with those service lines in doing it. We need to make sure that those other service lines we're working with are as efficient as what we have in our operating room, that we have block times. We're all aware of that. People show up on time, show up with your patient prepared. All the things that we do in our OR schedule needs to happen in NORA. But I do think we could use other professionals in our practice, and it could be other people that I'm not even mentioning, that we can train and oversee that can extend us.
Mr. Miller talked about the importance of acknowledging regional differences.
The data do show that the variance across the country is
Oh,
almost mind-boggling in terms of practice patterns, ratios of nurses to physicians, and things like that. In some places, when you bring it up, people get very concerned about the high ratios of CRNAs to physicians and things like that. But on a national level, the ratio still now, even though the CRNAs are putting out more than twice as many CRNAs per year as doctors are coming out, and they're going fast, we're still sitting at like 1.3 CRNAs to one physician nationally, maybe a little bit less depending on what numbers you look at. But for that, even at that rate of increase, for that to grow to some big number like 2 or 3 or 4, it's going to take years and years and years.
They both shed light on shifting ideas of flexibility within the evolving workforce.
The ASA had put on 2 anesthesia workforce summits 2 years in a row. And I think one of the themes that came out of it very strongly was people that seem to be very successful in recruiting and doing things is being extremely flexible with,
yeah.
I have people that want to work 60 hours a week. I have people that want this 8 to 5. I have people that will take call, maybe a 50% premium, whatever, but the models to adapt. It's not bimodal. It's not like
Right.
people that want to work hard and people that don't.
Larger groups have more ability, I think, to
I
do
was gonna
that.
say, yeah.
A smaller group does, but I know my son's in a very large group in Austin, and it's a really true market-driven model of call. All the partners have a certain number of calls that they have to take per year, but it can also go onto the marketplace where you can sell your calls, and calls are worth different value. And if there are more sellers than buyers, then the call pay goes up over a period of time. So, if you're taking call,
It's a great model.
if you're taking call at the level 1 trauma, that's going to be worth more than the overnight call at community hospital where you might do a couple little cases. And it works because it's a large enough group. And then you have people like my son who first degree was in economics, and it's like I have a young family. You're like,
That's good.
I want to pay off these bills. I want to do that. To your point, he's one of the young people that actually takes all the extra calls.
It's like,
But you got people that are closer to retirement and they're willing to sell them.
And the transition to hospital employment is a big one that now, and I think we both still agree that private practice is probably more productive and the numbers support that.
wow.
But as a hospital employee, I mean, they take on different roles and things like that. And so it now becomes the hospital's problem of managing these different types of people and their different desires in terms of work-life balance.
Finally, Dr. Peterson wanted to be sure listeners know where to go for more information.
Well, I just want to put a plug in for the Center for Anesthesia Workforce Studies. And so we have all this beautiful data and it's refreshed
charts.
It's refreshed every single month. And it's all archived on our website,
Yep.
hq.org. And you go to the cause area, CAWS, the website, and we've got all of our enduring materials from our workforce summits, solution driven, things that you can
Collateral
look at
materials.
that give you ideas of what might work in your own location when you're struggling to not close rooms, or what do I do? How do I talk with a hospital
Well, that's what I was just gonna
administrator?
say.
We've got even compensation data and what's happened there on various entities. And so it's very well done, and it's updated every single month.
Dr. Jonathan Gall, chair of the ASA Committee on Economics, and Dr. Gordon Morewood, vice chair of the Committee on Economics, added to the conversation, sharing their insights into payment models and more. Dr. Gall discussed a range of payment models, noting the newest value-based model, TEAM.
CMS has been trying to come up with some more engagement on these different models because there's still some of the same stuff. So they've got a new model called TEAM, which is another acronym, and I haven't memorized that one yet. It's essentially bundles all over again. They just have a couple new measures on that, and they want to try and encourage some gain sharing because the answer is money, no matter the question. They want to try and have people be engaged with it more by dangling some more money in front of it. But the reality of it is that the amount of money that they're dangling there is just not enough to get a proper uptake from it.
Dr. Morewood discussed some of the challenges anesthesiologists face transitioning from fee-for-service to alternative payment models.
One of the reasons that I think so many of the APM models have struggled to get off the ground, I mean, they all have the common theme in that the payers have figured out that they no longer want to pay for process. Fee-for-service payments is paying for the process. So you pay for every time you touch the patient, every time you do an x-ray, et cetera, et cetera. But what that stifles is innovation. People can't innovate around how they're going to care for patients because you're tied to the process. Unless you adhere to the process, you don't get paid. So alternative payment models ultimately are saying, here's the money, you guys figure it out. But making that transition from the fee-for-service to the alternative payment models, that's where they're having trouble. Anesthesiology is a great example. We sit at the center of so much extraordinarily expensive care, and we definitely can affect the amount of resources that are utilized to deliver that care. But how do you recognize that in an APM? And when you try and do this centrally in a system as complex as the U.S. healthcare system, it's a real challenge for the payers to figure out how to do that.
Dr. Gall talked about changes in CMS conversion factors.
They've come out with a conversion factor from CMS for regular non-time-based things like surgeries and primary care visits, E&M visits, evaluation management services. And then there's a separate one altogether for anesthesia. We have our own separate conversion factor for that that gets paid off for our base plus time. This coming year, there's now going to be 2 conversion factors for each one of those. And that it's going to be whether you're the have and have-nots, those that are in a qualified advanced alternative payment model and those that are not. Now, the difference in those conversion factors is really not much. It's literally 10 cents. Even if you did a 10-unit case, you got an extra $1. It's really not that much. The average case is usually about 12 units nationwide. So you can get an extra $1.20 per case with Medicare. Now, that's not really cascading with other payers out there, such as Medicaid or private payers now. They're starting to put a difference percentage-based wise between those who are in a qualified advanced APM and those who are not. This year, it's only 10 cents, but that gap is just going to get wider as years go on because it's percentage-based. The next year, that percentage gets up. Maybe it's more like 12 cents next year. The year after that, it's more like 14 or 15 cents, et cetera. So they're continuing to try and use money, again, to try and influence behavior then.
As Dr. Morewood noted, the specialty also faces challenges with commercial payers.
So the commercial payers used to be our friends, or at least they were the saving grace for the specialty. We used to have what was called a 33% problem, where Medicare paid us, literally a third of what the average commercial payer would pay us. And that's what kept most practices solvent. It was the fact that they actually lost money caring for Medicare patients, but they made it up on their commercial payments. We now have a 25% problem, so you can look at that as either good news or bad news. The Medicare has now fallen to 25% of the commercial payer rates. But what we're starting to see is that those commercial rates are not going to keep going in that direction. And they have become very aggressive in recent years about negotiating down rates, using some of the federal legislation like the No Surprises Act to try and erode rates even further, and then just frankly arbitrarily denying payment for a number of the modifiers that we use to indicate patient complexity that required more resources. So the insurers have made it pretty clear that they are just going to stop paying for the care that we are providing. That's the disappointing part, is oftentimes we have no choice. We're going to provide the care. It's not like we can look at the price of what they're going to give us and say, we're going to do this or we're not going to do this. We look after the patient. We do the appropriate thing. When they roll through the door, we then submit the bill and they say, but this time your payments have gone down by 20%.
As Dr. Gall noted, commercial payers have begun refusing to pay for physical status modifiers.
Last year, I believe it was Aetna who came up with a large policy where they were no longer going to pay for physical status modifiers. Now, the physical status modifiers is a classification system we use to base perioperative risk. So the sicker you are, the more likely you are to have a morbidity mortality associated with it. We have ASA 1, 2, 3, 4, 5, and then it kind of goes up in like complexity there. For an ASA 1 or 2, there is no extra payment requested for that. For an ASA 3, we ask for an extra unit, ASA 4, 2 extra units, and so on. Many of the private payers have been reimbursing us based off of that stuff on our claims. And it was just last year, Aetna started with saying that they were no longer going to acknowledge those on their claims. Just a one-sided policy, and they literally said it was about the money. United Healthcare has now piggybacked on that as well, and as of October 1st is no longer paying those physical status modifiers, and they've added on as well qualifying circumstances. So those are taking care of patients of extreme age, those less than 1 or over the age of 70, taking care of emergency patients, deliberate hypotension, hypothermia, those qualifying circumstances where there's obviously a lot of extra higher level care in those sorts of circumstances.
Importantly, Dr. Morewood explained how some of these challenges are being addressed.
Listeners need to understand that in the United States, insurance is regulated on a state-by-state basis. The state insurance regulators actually have a fair bit of control over what the insurance companies in their states do. And that has been a large part of the ASA tactic, is to go state by state, working with the members that are in that state, working with the state legislators, working with the insurance regulators, and saying, you are the only individuals who can hold the insurance companies to account, so please do your job. They've collected money from their customers to provide health care, and then they're just simply keeping it in their coffers, having it flow to the bottom line in record profits, and are not paying for the patient care that their customers have paid for. You need to do something about that. And so far, we've had some reasonable success.
ASA is fighting to ensure the implementation problems in the No Surprises Act are resolved to the specialty satisfaction.
There's been multiple different lawsuits filed related to the implementation of that legislation. Most of them filed here in Texas, where we are right now in San Antonio. So the Texas Medical Association has been the one who's led the charge on that. And then the American Society of Anesthesiologists has filed amicus briefs in support of each one of those. And fortunately, we won each one of them. And they're about different areas within the implementation that were just botched by the federal government and level the playing field between the providers and the payers.
Yeah. And it's important to note that when people actually manage to get through the process of the NSA appeals, physicians are winning. Anesthesiologists are doing very, very well. They're actually winning the majority of the case, getting the payments that they expect. So the process can work. It's not necessarily a bad concept. And I think the original legislation was actually well written with input from the ASA at the national level. But the problem has been the implementation and the rule writing. If you're an ASA member and you're listening to this podcast, or if you're not an ASA member and you're listening to this podcast, understand that the ASA is deeply involved with each of these processes. They're fighting in the courts every single step of the way, trying to make sure that you have a fair shake under the NSA.
ASA is implementing long-term economic strategies as well. As Dr. Morewood explained, the Center for Anesthesia and Perioperative Economics, or CAPE, is leading the charge.
So one of the major initiatives of the ASA over recent years has been the establishment of the Center for Anesthesia and Perioperative Economics, which is ultimately going to become an independent think tank. And their express purpose for existing is to develop 3 to 5 year economic strategy plans that will help influence policy, will help influence payment schemes, will introduce tools to individual practice to be able to navigate this environment that we're in now. And one of the aspects that they're looking at now is rationalizing some of the Medicare regulations and language around anesthesia, because so many of the private payers now are defaulting to Medicare regulations and saying, well, we're just going to do what Medicare does. Yeah. For so long, I think the specialty kind of ignored the Medicare regulations because they were such a lousy payer. We didn't really worry too much about it. We focused on our private payers. Now that the private payers have jumped on the Medicare bandwagon, there is a burning impetus to solve some of the inconsistencies and irrationalities in the Medicare policies.
We've got 3 different work groups right now as part of CAPE, really trying to incubate these ideas and come up with some early low-hanging fruit wins. So we're working on trying to advise anesthesia practices on there's ones that demonstrate value.
And finally, yet again, the rich content on ASA's website was touted as a useful resource.
We try and post things that we think will be of interest to the ASA membership in general. We have a whole library of timely topics where things come up, and we post short, digestible articles there on the website.
AQI initiatives were the topic of discussion with Dr. Sheila Barnette and Dr. Patrick Guffey from the Anesthesia Quality Institute. Dr. Guffey explained how AQI uses data to help clinicians improve the quality of care and talked about how AQI is evolving.
So the work of the AQI has been an evolution over time. It really started with one primary registry, which is called NACOR, and NACOR, the National Anesthesia Community Outcomes Registry. And the purpose of that registry was really to learn about what's going on in our specialty and then give us the information necessary to improve. And then AQI runs a couple of other registries. One I'm really familiar with. I get the privilege to serve as the chair of it, which is the Anesthesia Incident Reporting System,
Yeah.
which is where we get information about all of the either near misses or cases of harm that come in that happen to our patients. And then we produce an article in the Monitor every month that looks at a case. And then finally, the closed claims database was adopted into AQI. I think it was back in 2018, if memory serves. That came over from some work that was done out of Seattle. And that's a really powerful database because it looks at what was litigated and closed. Game was closed out and what the result of that was. Now, where we've had opportunity is going back to NACOR. NACOR has really been collecting a lot more of administrative data than clinical data. And the reason for that is that data just happens to be a lot easier to get. The way the surgeons have been able to do this is with a lot of manual abstraction. That's how NISQIP and other registries work. We've always approached this from the space that we need to be able to get electronic data because we don't have those same resources of asking the hospital to hire 5 abstractors
Yeah.
for everything and go through the chart. As you might imagine, that's given us a lot of administrative data because billing and coding and all that tends to be very discrete structured data. What our evolution has been is how do we get the clinical data so that we can answer a few key questions? We're really trying to frame this now as an outcome registry.
Yeah.
So what we really want to be able to do is answer the questions that, when you think of an anesthesiologist doing a case, there's certain things that we're doing that probably have implications that we don't know about. And there's other things that we're doing that probably don't matter. And when you're trying to influence how anesthesiologists provide care, physicians in general want to see some evidence. So we need to be able to produce that evidence and say, we'd like you to standardize on these things because we have good evidence that this helps. But when it comes to these other things, do whatever you think is correct between you and the patient because we don't have a strong preference based on the data. And we need to be able to provide that service. And we need also to be able to, in this financial climate, we need to be able to determine value.
Yes.
So if you think of that equation where you've got the service times the quality of the service divided by the cost of the service, that's value. And for far too long in medicine, I don't think that cost component has been figured out. So if we do an intervention in anesthesiology as part of our practice and we see a very slight benefit that has a very high cost, we need to be able to communicate that to our community and say, for most patients, you're adding cost to an anesthetic and you're not getting a huge benefit out of it.
Yeah.
Those are the questions we want to answer.
Dr. Barnette connected some more dots.
So I think what the opportunity for NACOR is and for AQI is, we get data on maybe how you do 10 days afterwards, 6 hours afterwards, or whatever. But the anesthesia itself has often been a bit of a black box because from a paper record, it's really hard to extract what the blood pressure was or what time you really gave the med or what time the intervention really was. So I think this will allow us to get much more granular data on what we're doing and what we control, as opposed to just being batched in with complications of surgery.
Yeah.
Lap choles, ACS data from the American College of Surgery, we're kind of batched into that as was it general anesthetic or regional. This will allow us to have a lot more granular data on, well, did those drugs like dexmedetomidine really make a difference? Or did they prolong things? And then getting back to the value-based, I'm really into geriatric anesthesia, and that's where, we have hundreds of patients overwhelming the system in a way. Shaving off a day length of stay and stuff like that is a huge thing for overcrowded hospitals. And so what can we do in our anesthetics or that preoperative, perioperative part beforehand?
AQI is innovating around data integration, as Dr. Guffey explained.
So each individual site on their electronic health record, and probably more importantly, their AIM system, which stands for Anesthesia Information Management System, they have, like you said, millions of data points. Getting that data from that individual site to the AQI in a structured, standardized way is a much larger lift than most people would anticipate. And then the other problem is you have a software company that continues to innovate. So things change. And in some cases with Epic, we're doing quarterly upgrades.
Yes.
Imagine 4 times to here, you're trying to go back and optimize all that, and you're having to run servers in your own shop. you need your IT teams. And for better or worse, this may not be the highest priority of your organization, comes at significant cost. Epic has something, an internal registry called Cosmos, which is where they're already taking data from individual sites, they're blinding it, and participants can use the data to answer research questions inside of Epic. So they built that structure, and they're doing some very fascinating things with it. What we're looking at doing with Epic and what they built for us to be able to do is to take those data feeds from the individual sites and instead of pointing them at Epic's registry, point them to the society.
Yep.
So we're able to know what patient, what information, and then that goes into the database at AQI. Then we can take data potentially from other EHRs, whether it's the Cerners of the world or others, mix that in, and then start to get a real picture, not just of the administrative data, but of the clinical data. Now, what's also fascinating about this is if you just go after the anesthesia data, that AIMS data, you're not getting all these longer term outcomes. When you're partnered with Epic in a EHR, a true electronic health record, you have all that. So now we can start to answer the questions like, when did they go back to work?
All right. Yeah.
When did they go back to school? We have to parse apart what was our contribution and what was the surgical contribution, because right now our contribution ends in the PACU or when we drop them off at the ICU. We know that's not reality. Reality is the decisions we make in the OR may have long-standing implications. We need to know exactly what they are and how to optimize them.
Dr. Barnette drove home the value of metrics for anesthesiologists, as well as patients and systems.
When the surgeons are looking at the patients, they're looking at down their road. I'm orthopedics, I'm cardiac, I'm colorectal. Whereas in anesthesia, we're taking care of all of them. So if we make changes in one area, it's very easy for us to extrapolate it and use it across the board. So we can really make those quality improvements much more broadly and also then watch the value a little bit more closely for all the different areas. And I think that's a huge one. Being able to link some of the post-op part to the intra-op, I think will be really powerful. Another real big advantage I see with this is a lot of us are moving from individual hospitals to health systems.
Yes.
So in my system, we have a couple of different hospitals. We have different styles of practice. We have some independent nurse anesthetists. We have physicians, directed, solo physicians. This is a real opportunity to sort of say, okay, we have quality that we're looking at in all sites, bringing it back in a non-punitive way that you're not poking into somebody's hospital or what they're doing. We're all one department then, and we can have equal benchmark across quality standards across, which I think this would be really valuable for.
Finally, Dr. Barnette noted that the specialty of anesthesiology is at the center of AQI's efforts.
And I think it's important for anesthesiologists to understand too, this is our registry. It's going to be about us, what we want to do with it, how we can empower our specialty to get even better and bigger and really show our perioperative value even more. And I think that's really important. Epic is obviously, central to this. The data is going to be fantastic. They're great to work with, but it is still coming back into an anesthesia registry. And I think that, that hopefully our members will feel trust in that, the ability to question and ask and use us.
Lastly, we tuned into Dr. Samer Narouze, who spoke about the newly formed Pain Medicine Coalition.
This is like a transformative effort to help the pain medicine community in general. So it's an alliance, strategic alliance between the American Society of Anesthesia and the other prestigious pain medicine organizations, namely the American Society of Regional Anesthesia and Pain Medicine, which is a devoted society for the whole spectrum of pain, from preoperative, acute, postoperative, chronic pain, and rehabilitation. And also we are having strong ties now with the American Academy of Physical Medicine and Rehab. They have different skill sets that they bring to the table, a very prestigious society. And the fourth organization is the Interventional Pain Spine Society, which is the focus society from the PM&R physician in chronic pain, MSTK, and spine rehabilitation. So this alliance between those four strong organizations, we believe that this will transform the field and we will be the number one advocate for pain medicine, physicians as well as patients.
You discussed the importance of patient access to care.
There's too many barriers for patient access to appropriate pain care. First is the lack of qualified pain physician, board-certified pain physician trained in the multidisciplinary approach. So this is the first barrier. The second barrier is the insurance barrier, the lack of coverage for some of the non-opioid modalities of treatment. As much as we want to avoid overuse of opioid prescriptions, we want, on the other hand, to make non-opioid treatment therapies available, whether pharmacological or interventions. There's lots of requirement from third-party payers and the CMS, like prior authorization, denials. You have to try ABC first before you move into this. So we are working through legislative effort, through advocacy policymakers, to remove those burdens and obstacles and layers of bureaucracy that prevent access for the poor pain patient to the appropriate treatment before it's too late and the patient's crippled from pain, and then we worry about how we rehabilitate the patient and make them a functioning citizen in the community.
Dr. Narouze discussed the costs of acute and chronic pain and the import of managing acute pain early.
In USA, we have millions of patients suffering from chronic pain. It's a long-lasting disease. It's life-changing can be. So it's always better to prevent acute pain from developing into chronic pain rather than managing the challenge of rehabilitating patient with chronic pain. We have data now to support that appropriate management of acute pain would eventually prevent patients from having chronic pain. On the other hand, early intervention of chronic pain will prevent disability and loss of function, loss of work hours.
And he explained how the Pain Medicine Coalition might help clinicians and patients.
We are advocates for the pain community, patients and the healthcare clinicians, pain physicians. So access to patient care, but also reimbursement issue and coverage for the procedure and the pain physician, because it's quite frustrating for both ends that your hands are tied. You are limited by the options that you give to your patient. Someone else is making decisions for you. So the ASA, through its legislative effort, working on the federal level, on the CMS level, on the AMA level, on state levels, to support legislation that will make non-opioid treatment available, like the Alternative to Pain Act. We are a big supporter of it. This should prevent prior authorization, should prevent out or limit out-of-pocket money for non-opioids, basically making non-opioid therapies as easy and as accessible as opioid prescription. You can go, you can leave the office with an opioid prescription. We should make it easier to have access to other treatment options the same way. Honestly, what we are trying to establish here is to rebrand the pain medicine field. It's really a transformative effort to change the image that it's either opioid or it's a specialty that focus only on interventions. No, the pain medicine will be deep specialty that cover the whole aspect of pain in a truly multimodal approach, deeply rooted in neuroscience, evidence-based medicine, patient-centered care that support each step of the therapy. So we are kind of not just rebranding, but re-establishing the integrity in the field, that this will support not only physicians that we represent, but we are also the number one advocate for pain patients.
Dr. Narouze's passion for patient care will resonate with many listeners.
If I have to choose it again, I would choose pain physician because you make a difference. Pain is an experience. It's not just you feel the pain. It's the way you react to feel, the experience that comes with the pain. We have to understand the whole picture of chronic pain, the psychosocial economics of pain. It's not just you need to remove the cause of the pain. You need to treat the consequences that this pain left behind. Depression, anxiety, isolation. So that's why I'm saying we are rebranding it. It's not just medicine to treat one aspect or an injection to block this nerve. No, this is one piece out of the whole picture. We need to treat the whole patient to make again the patient functioning and forgetting this bad experience with pain, not just removing the cause of pain. Removing the cause of pain is number one, the step, but you have to treat the consequences that happened from years and years of pain. So that's why it feels great that when you see the patient coming back with family members, I have my family back. I was able to go to this wedding, able to travel, attend the graduation of my grandson. This is priceless.
That's a good place to leave this episode and wrap up another fantastic year of podcasts. Thanks for listening to this recap of TopMedTalk's conversations with some of the biggest thought leaders in our specialty and within our society. And thanks to all of you for listening to Central Line throughout the year. We look forward to another wonderful year of podcasts upcoming for 2026. Come back soon for more Central Line. Take care.
The business of anesthesiology continues to evolve. Gather fresh perspectives, transformative technologies, and practical tools to help your anesthesia business succeed at ASA Advance each January. Get the latest info at asahq.org/advance. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.